So, really quick look at a few more tests that we're going to look at. CT examination. What I'm going to do is actually do a superior sulcus sum. So, what the main thing you want to do is patient's arm rested right here, just nice and relaxed. I'm going to come up here and stabilize the top. Put my hand here just to be able to feel it, and now I'm just going to give a little inferior glide. And what you're looking for is that sulcus sign, where the skin's kind of tethering a little bit, showing that hole. Just kind of down right there and go. If you're looking at normative values, 10 millimeters is actually pretty normal. But of course, like any test, we always want to do the opposite because generally there should be a one-on-one correlation between both sides. Why this is important and why I started this off first was because generally, if this has increased laxity, the anterior and posterior position is going to follow suit. So if I know that going into it, I can be much, much more careful going forward. Of course, we want to be careful based on irritability level, but if I think they have a very kind of lax shoulder, etc., then I want to be very careful with that. We're not creating more instability. Also, something to note that this test is actually truly positive if it reproduces the symptoms and has a laxity. If it does just the laxity but no symptom reproduction, then it is considered just a laxity, just a hypermobile shoulder, but not a symptomatic shoulder. The next test I'm going to go through is a part of that examination we just did is the anterior load and shift test. So what I'm basically going to do is kind of have the shoulder right here, just nice underneath, kind of grasp right in here, and all I want to do is just give an anterior translation. So according to the test, what you want to do is just check it from about 0 to 30, about 30 to 60, and then check again exactly where I'm at in the sense of 0 to 90. So just so you can get a better look at that. There we go, 0 to 90. A part of that, what I'm actually going to test as well, is a posterior load and shift. This one you only really want to do at 90 degrees because that's where the capsule and the posterior is kind of laxed a little bit. So all I can come down here and just give a posterior glide just like that. And I should mention where my grip is, I'm actually going posterior medially, where the other one I was going anterior lateral, because that's the true plane of the glenoid. If you're not in that true plane, you're actually probably going to get a false negative because you're not going to have that motion because you're just banging the head into the glenoid a little bit. The final part of this as well is come down here, even though I did just check the inferior glide, come down here at this point and inferior glide just like that, just to check it as well. Now, the next part of the assessment is going into the AC joint. So, how I want to assess that is a couple of ways. I can do a PA glide, an AP glide, and also kind of an inferior glide of the area. So, generally, I come down. What I can do is just kind of follow the clavicle out, just get right to where the search is on that chromium. And first, what I'm going to do is do a little bit of a inferior glide, just like that, just to see does that reproduce symptoms and just see the joint play. Oftentimes with this as well, what I'll do is I'll go down to the SC joint, so follow that along, get right into there, and go just like that. So just kind of check both of them, and even sometimes you can check both sides at the same time, going down just like that. So next, what we do with both of those is give a anterior to superior glide. So what I can do with that as well is come right into here, get right onto that joint. What I want to do, anterior to posterior. So find that joint line, come down, and come right down just like that. I can come and do the same with the SC joint and doing just that right there. I'll be honest, I don't go APs as much unless I can find the comparable sign. But where I do find it beneficial, especially for the EC joint, is doing inferior glides, especially if you're having issues with, say, abduction or flexion. Oftentimes, if you go to the SC joint, work it inferiorly, though you're not getting a lot of degrees of motion. If you think it from a lever and biomechanical standpoint, little degrees there can mean a lot of degrees at the end. So that can play a huge factor into it. And the clavicle does have 30 to 35 degrees of motion as it goes. Also, important to note too, from the AP direction, if I do have a problem with scapular retraction, in theory, I can actually affect it through the clavicle as well. Now, going from that, what we can do is go straight into the glenohumeral joint. So depending on the patient is where I'll start off with, but a lot of times what I'll do is start off here and just go and just have it relax a little bit. So first what I can just generally do is just see what I got. I can easily distract. So just weight shift here and just see what's kind of playing to the joint. Then what I can do is supine, just come here, just almost like the load and shift test, etc. is I can just kind of see how the joint is moving even before we go into a lot of motion. This actually can turn into quite a big of a treatment as well, depending on what's going on. But I can come in here and just kind of going down and going up. The next thing I check out as well is the inferior glide. So coming down here, as long as we come up, what I'll actually be looking for is just to play, but if I'm going for a posterior glide, go just like that. So posterior lateral. So my angle of the joint is actually here. Now, for some reason, when we go anterior medial, it's actually going to be like that. I want to come on down here and just play the joint just like that. Alright, so for the next portion, what we're going to do is look into quadrant testing. The way it kind of showed in the book was actually how I learned to treat it, so I'm going to show the way that I kind of learned to assess it a little bit through the COMT training and everything like that. So, back here a little bit. What you want to do is you go into actually multiple ranges. Now, before you test this, you have to rule out any type of possible instability because, as you'll see, you're going in a pretty interior positioning with the quadrant as well, so you want to be kind of careful. So what you want to do is take the arm, come under here, and kind of brace here. So I've got her kind of blocked, got her leg against me, and all I'm doing is just going here and just checking quadrants, just seeing if we have any familiar symptoms or anything like that, and we can actually kind of work her way up just like that. And so what I'm actually doing is she's nice and relaxed, because this one they have to be very nice and relaxed here, and going out into the corners just to test right there while I'm kind of back here in my underarm blocking the way. Of course, like I said, this always can come into treatment. What you're going to do more, of course, depending on your grade, is going in here, and then if you're actually going to go into the grade 3s and 4s, you actually need to come from the back into this position. So that looks like coming from here and then just going down. But we won't go into that since today is merely just assessment. The next portion will go